So the first project I wanted to talk about with you was a project that we've been doing over the last few years with our partners Christian Medical College in Tamil Nadu, in Vellore. And that was a project on cervical cancer screening in very low resource settings. So in that project we took up the work that Professor Rita Isaac has been undertaking for the last decade or so, and tried to add in some new strategies which would hopefully improve uptake in her sort of target populations. Rita has developed a strategy for reaching low health literacy people that involves a whole range of media strategies. She uses puppet shows. She uses all sorts of ways of trying to make prevention and cervical screening understandable to a very sort of underprivileged and underserved population. It has achieved quite commendable screening rates in that population. Our project was to continue that work, but also to see whether a mobile health intervention using mobile phones might increase uptake. So far, the results have been encouraging. We've found that community health workers really sort of take to using mobile phones. We're talking about settings where the data infrastructure, or information infrastructure, is really quite challenging. They don't have disease registers like we do. They don't have the same sorts of cancer screening registers. So this project was about trying to overcome those difficulties using mobile phone-based techniques, whereby information about screening was entered into the mobile phones by the community health workers and collected centrally. We've had good uptake rates. It's difficult to get an exact idea of uptake rates because we don't really quite know the denominator population, and we've found that the community health workers have as I said, really taken to these mobile phones and using them quite well and quite effectively for the data entry. Yes, indeed. Yeah. So we partnered with a organisation called Medic Mobile. Now they are a non-profit organisation. They're very interested in using mobile health strategies to overcome all sorts of health issues in low and middle income countries. They've not so far done a lot in the area of cancer screening. There's been lots in sort of maternal and child health. But I think there's just enormous potential to roll out this idea in countries such as India. Whilst a lot of the areas of India are quite under-resourced, it's quite amazing the level of mobile phone coverage, and almost everyone carries with them a mobile phone. So we only just began to explore the potential, I think, in this area. We could, the next steps might be to sort of send out health promotion messages or prevention messages to women, and reminding them that they might be due for cervical screening, emphasising some primary prevention messages and so forth. Yes, so the project I'm talking about is the International Cancer Benchmarking Project. Now, several people here at the conference representing that project. It was a project which was led by Cancer Research UK, and it is interested in comparing cancer survival in a whole lot of different countries around the world, and trying to understand those differences. The countries included are the countries within the UK, Norway, Sweden, Canada and Australia. There were different aspects to the International Cancer Benchmarking Partnership. One module looked at awareness of cancer symptoms and how people respond to them. Another looked at the response of primary care and family medicine to patients presenting with symptoms. The module which I co-led on, which was module 4, we looked at routes to diagnosis. So how much time did people spend thinking about their symptoms before they presented? How much time did they spend in primary care once they'd presented with their symptoms? Once they were referred, how long did it take to get appropriate treatment, and so forth? And we did a comparison of those routes to diagnosis in these participating jurisdictions around the world. We also looked at whether people presented to primary care first, or whether there were emergency admissions, whether their diagnosis was through screening. So a very labour-intensive but very interesting international comparison exercise. Well, we found intriguing differences in the cancers that we looked at. So our cancers of interest were breast, bowel, lung, and ovary. And for each of those cancers, we recruited 200 people in each of the participating jurisdictions and sent them questionnaires. We followed up for the non-responders about those various time intervals. What we did find was that for all of those intervals, there were demonstrable differences between the jurisdictions, but they didn't necessarily occur in a way that we might have expected. So, for example, in countries with poorer survival rates, we didn't necessarily find longer primary care or diagnostic intervals. One of the frustrating things about doing research is that often when you get the findings back, they're not quite what you expected. However, for each of the cancers, we're just sort of completing the analyses and writing up now. But for each of the cancers, we were able to show that, demonstrate differences in each of those intervals. And those findings have been of tremendous use for the local jurisdictions. So, for example, if a jurisdiction found a longer primary care interval, that might prompt them to look at what's going on in primary care and see if there were ways of streamlining the process. There's sort of too many results really to present in this interval, but what I think the work does show is that there really are quite demonstrable differences in route to diagnosis around the world, and I think we can learn from those differences by exploring what's causing them, whether it's patients taking too long to appraise symptoms, whether it's taking GPs too long to respond to those symptoms, make referrals, whether our treatment and diagnostic services are up to task. Yes, and in fact, when I said the research was led by Cancer Research UK, there were a very large number of partnerships around the world which made this happen. That included not just cancer charities, but many departments of health in these various jurisdictions. What's happened is that in each of those jurisdictions, the researchers have been working with their local champions, their local leads in cancer, their colleagues in departments of health, to examine the findings and explore what actions that might come from them. For example, one of the jurisdictions was in the state of Victoria in Australia, and they found some very interesting differences between the amount of time it takes to get diagnosed if you live in the rural settings as opposed to urban, and that's very sort of hot priority for the Victorian government at the moment. So they've really sort of shone a light on those sort of routes to diagnosis, which I think have been very helpful in driving further research, but also in setting policy and direction. I'd like to think so, because you know, the results are unique. We've never really tried to make these international comparisons in this level of detail before. One of the things which really drove this in the UK was the fact that survival rates from these common cancers in countries such as England and Scotland and in Denmark were demonstrably lower than other comparable European countries and countries such as Australia and Canada. So that's been a real drive for action and to respond to those differences. And I think you're right. There's a huge amount of interest at the moment in pathways in cancer. So diagnostic pathways which might perhaps involve direct access to investigations by GPs, investigations such as colonoscopies or CT scans, more streamlined referral clinics, ways of getting people through the system more quickly. I think there's great interest in that, and these sorts of data where you can benchmark how your country is doing compared to others, and then look at those other countries and say, well, what are they doing that we're not doing? I think that is of great benefit. And as you say, I think it could translate to patient benefit relatively rapidly.